This video is a two-part video. It contains information about the DSM, but it also has information about the intake assessment, a particular assignment that you have a little bit later in the semester. So let's start with the DSM. This particular week, we're covering other conditions that may be a focus of clinical attention. And we really need to start this conversation by talking about why a counselor would use one of these codings. And what it really comes down to, in my opinion, is your ethical and professional responsibility to provide an accurate assessment, an accurate diagnosis for why a client would come to see you. You do not want to create or modify a diagnosis to fit any external criteria. Typically, what I really mean is that typically counselors, other mental health professionals, will assign a diagnosis that they know that an insurance company will reimburse for. And I know this, we'd think, oh no, we'd never do anything like this, but I've been in the field long enough to know that this is a reality for what organizations, individuals will do. And I'm here to tell you it's not ethical. In a way, you could be committing fraudulent behavior, which could come back and bite you to a certain extent, whether it's having to pay back an insurance company or being reported to the licensure board for your professional behavior. So I want to cover some typical diagnoses and just briefly discuss what it might look like, how a client may present, and why you would use this as a diagnosis. But I want to just give a disclaimer that this is not a complete list of the different codings that are provided. You would want to refer to the DSM. I've got some notes on my notes. I believe it might be page 715 or 727. I'm not sure why I've got two different page numbers here, and I don't have my DSM to quickly reference it, but it is in the latter part of the book. These conditions that may be a focus of clinical attention. Just a little bit of random history here. If you've been in the field in the past, or I guess really specifically I should say, if you've used an older version of the DSM, you'll know, or before, you will know that DSM diagnoses were given in a multi-axial format. Now there's just one axis. You give just a diagnosis. But previously there were 5 axes. You had to in order to give a complete diagnosis, you had to have some indication across all 5 axes. The first axis was your type 1 diagnosis. It was your typical diagnosis: depression, anxiety, schizophrenia, whatever you were addressing. That was axis 1. Axis 2 had to do with personality disorders or intellectual disabilities. Axis 3 had to do with general physical conditions that may be contributing to the axis 1 diagnosis. Axis 4 were what were called psychosocial stressors, which very well could have been indications of what we're talking about today, although there have always been these other conditions that could be a focus of clinical attention. But it would be a way to further describe things that were occurring with your client. So if they really were coming to see you for depression, that would be an axis 1 diagnosis. But they also might have housing problems, and so you might indicate that on axis 4. And you didn't need to give a coding, you just wrote out what these stressors would be. So that was axis 4. And axis 5 was what's called a global assessment of functioning, or a GAF score. So you'd rate your client on scale of 1 to 100 in terms of how well they're functioning, and that was always a point of contention because it was really a subjective type rating, despite the specifications in the DSM for how you could rate someone. It still was open to interpretation. So things have developed and progressed, and as we shifted from the earlier versions of the DSM to the DSM-5, it's just a single axis, a single coding, single diagnosis, and you can have multiple diagnoses within this singular axis, but it's still considered just one diagnosis. So you'll see some of the list here about other conditions, and the top one I think speaks for me the most relevant, or perhaps the most best example to demonstrate why you really need to be ethical when you're rendering a diagnosis. I want to go ahead and tell you I maintain a private practice in addition to teaching full-time, and one of the populations that I see are couples. I see couples that are coming in for couples counseling. And diagnosis is always a tricky issue. I typically tell couples, initially I don't bill insurance anyway, and that's an intentional decision for me. I have previously in the past, but it's not something I want to do at this point. But I also will tell couples counseling is not really something for which you can bill insurance anyway. And so what some unethical practitioners will do will render a diagnosis for one person within the couple, and they bill insurance for that particular person. And they might think they're doing a favor for this individual or the couple and being able to get insurance to pay for the services they're providing or receiving, but I do not recommend, do not encourage, and would not condone this activity. What you more accurately should do is render a diagnosis related to relational problems. That is the reason why they're coming to see you. Certainly there may be other issues. There might be one of the people in that relationship that is depressed, experiencing stress, anxiety, which could contribute to the relational problems. But the reason why this couple would be coming to see you or see me, the identified problem, are the relational problems. Now, if depression needs to be addressed with one of the individuals, there'll be a school of thought to which I adhere to, is that you need to refer that individual out to another counselor. So they would have their individual counseling with that individual counselor who is addressing the depression, and they would bill and render a diagnosis of depression. But if you're the counselor that has seen the couple and is seeing the couple for couples counseling, depression is not within your purview of what you're doing in the counseling experience. So you would render a diagnosis related to relational problems. So that's an example of kind of how this plays out. But there are other ones that you will come into contact with in the context of your work, and you'll have to make a good clinical decision as to kind of the primary reason, or maybe it could be the sole reason why you're seeing someone. Abuse and neglect could be related to child abuse or neglect, physical, could be sexual, could be spouse or intimate partner violence, that type of abuse, neglect of an older individual. Just depends on what you're presented with. I think what would be critical in your assessment and determining what you're doing in the resulting treatment plan is to really think about what's going on with the individual that you're seeing and their specific needs. So with lots of people that I've seen who perhaps have been victims of abuse. Let's just say the typical one I see would be a previous childhood sexual abuse. Now, you could think that's the primary reason I'm seeing them, but in most of the cases, what I see as a clinician are symptoms of post-traumatic stress disorder, which we'll cover in a later segment. But that would be the diagnosis in that case. So you really have to determine, am I seeing this individual because of other mental health symptoms that certainly are taking a priority, such as PTSD, or is the reason that I'm seeing them really because of the abuse and neglect? And perhaps addressing that, helping them get through that, and there are no other symptoms present, then that might be the reason to render this type of diagnosis as the only diagnosis. It could very well be that this is going to be a secondary diagnosis. It's in addition to, for example, PTSD. And PTSD would be the primary diagnosis. Now, there's also educational or occupational problems. So people are coming to see you because of difficulties they're experiencing within the educational system. It could be that they have lost a job, and if you're seeing them for career counseling, for example, then their primary diagnosis might be occupational problems. You would render that as the diagnosis. Housing and economic problems. So if financial stress is creating a lot of the issues for them. If they are without housing or homeless, then this could be a primary or secondary diagnosis. That perhaps would be something that might fall more in the realm of what's typically called case management. It's in addition to the counseling that you're doing. It's not something we really prepare or train individuals for within a counseling program. Those are skills, in my opinion, you kind of learn on the job in the field, how to help people with housing or economic problems. It can become part of a treatment plan, but just be clear that this is not something that is perhaps counseling in nature. The types of skills you would use within the counseling experience are not case management. Problems related to crime or interaction with the legal system. So if you're interacting with a client, have a client who is involved with justice system, juvenile justice, active court case, things like that, that's creating stresses upon them, then it very well could be a primary or secondary, most likely secondary type of diagnosis. So that's other conditions that may be a focus of clinical attention. I'm going to pause just for a minute and just recommend that if you have questions related to these types of diagnoses, when to apply them, then I would encourage you to reach out to me through email. Just ask away with your questions. So let's move on to the intake assessment. Now, I've already shared with you that I have a private practice, and in the resulting screens and the template that will be on Blackboard is a sample of what I use in my own practice. Each initial time that I see a client, I conduct an intake assessment. And I generally preface my conversation to my client, that I'm going to ask you lots of questions. Some will be relevant, some irrelevant. Some will sound crazy. But what I typically will tell people is that consider this like going to see the doctor for your annual physical. Consider this a mental physical, in that I'm kind of checking everything out to make sure everything's functioning well, functioning the way it should, that you're not experiencing any other types of symptoms that need to be addressed. So, bear with me as I ask some of these questions. So that's how I'll set it up for a client, and that allows me a little bit of latitude to ask and probe in multiple areas. Now, the document itself is something that I developed personally, combining a couple of different things. So when I first started in the profession, I worked for a county mental health center. These entities no longer exist, in case you're curious, at least within North Carolina. Privatization of services in the early 2000s are what kind of did away with county mental health centers and implemented entities that are known as local managing entities, or LMEs. They help to triage and really monitor and manage care for the same types of people that were typically seen in county mental health centers. So I borrowed some of the questions from those documents. They had their own paperwork. It was state paperwork, required of any mental health practitioner working in a mental health system across the state had to use the same type of assessment instrument. So I borrowed some of that. I also went through my DSM to make sure that I was kind of hitting the high points of every particular symptom category of disorder, that I could kind of as quickly as I could, run through a series of questions to make sure that I'm checking everything out. Now, I wouldn't consider this to be a perfect document. I'm certainly open to editing as time goes on, but I believe what I'm showing you is almost identical to what I'm using right now. I've changed, obviously, the information at the top to include my private practice information, but I think the questions, for the most part, are very similar. Now, it doesn't contain, word for word, the types of things that I would actually say to a client. I'm going to run through this to kind of demonstrate the types of things that I would say or do to a client, to give you some context of how this element is used in practice. And when I am sitting with a client, I'll go ahead and tell them initially that my intake could take up to an hour and a half, depending on how quickly we go through things and go through the initial paperwork. I typically do have a paper copy of this instrument. I've tried going through it digitally as well. I think I prefer to have just a paper copy for myself as I'm doing this. So I've got that in front of me, and I've got a pen, and I'm filling out most of it as we go. I don't want to perhaps rely on memory when it comes to some of these issues. So you'll see at the top the title, Individual Intake Assessment, and you can see, magnifying this a little bit, writing the client name, the date of birth, the date of the intake. At the point in which I'm seeing them for this, I generally know if they are self-referred or if someone has referred them to me, a physician or fellow colleague. That typically gets filled out in my initial paperwork. I also have my private clients to complete a form online that's HIPAA compliant and tells me why they're seeking counseling, and I'll fill in that part, the chief complaint or presenting problem, based on how they filled out that form. Also on my form is asking if they've been seen by someone else, if they've received counseling before, so I can knock out the previous current treatment as well during that time. I'm mentioning this because these are things that you perhaps through the course of your assignment will want to go ahead and ask. So what brings you in today could be getting the same type of information for that chief complaint or presenting problem. Have you ever received counseling before? Are you in counseling right now? Can be a way to get at the information for previous and current treatment. If they've not received any treatment or have never been in counseling before, not in counseling now, just put an N/A, not applicable, in this block. try to do it rapidly so that you're not sitting writing and writing and writing before you ask your next question. And then we move on to family history, so some easy types of questions. Do you have any brothers and sisters? Are your parents still living? If so, are they still together, still married? If not, what happened? When did they separate? When did they get divorced? How old were you when that happened? Do you have any step-parents if they're remarried? Any step-siblings? For children, this will be particularly important information. You want to have a basic understanding of who's living in the house, what are the relationships like. So you can ask some follow-up questions with respect to that. This element related to pregnancy and birth is specific to your client. So to your knowledge, did your mother have any complications when she was pregnant with you and during your birth? Are you single, married, separated, divorced, and so on? It's just a checkbox. How many times have you been married? Is this your only marriage if you're married? How long did each one last? If they're currently married, so you'd want to know how long they've been married. If they've been married and separated or married and divorced, how long did that last for each relationship? Is there a history of any mental illness in your family that you're aware of? And I'm really trying to get information specific to severe mental illnesses, history of depression in the family, bipolar disorder, schizophrenia. Those are pretty much the high things the high points I'm looking for. But there are other elements that, there's genetic basis for ADHD, for example. So allow them some time to think back through their family tree, see if they recall anybody. And lots of times you'll get responses of, I have this aunt and I know something was going on with her, but nobody ever really mentioned what it was. And when I get responses like that, then I typically will ask a follow-up question. Well, what types of things did she do? What were you told about her that was going on with her? Because lots of times there's history of bipolar, for example. Nobody ever mentions bipolar, but there's lots of things that have happened, bizarre behavior, whatever the case is, that everybody's aware of what happened, but they just don't put a label on it. So inquire, just in general, what did you hear about this relative? What were they doing? Current living arrangements, so where, who are they living with, how long have they lived there? I'll ask, do you feel safe at home? Do you feel threatened in any way? Moving on to education and childhood. What's your highest level of education? Have you been in the military? If so, what branch were you in? How long were you in? What was that like? Have you ever had a history of learning differences, difficulties in school when you were in school? How would you describe your experience in school? When you were in school, how many friends did you have? Did you have a few good friends? Did lots of acquaintances? Hardly any at all? With these friends, were they your age? Were they older, younger? Those types of definitions, whether older or younger, could speak a little bit to developmental differences. So people that you see who typically had friends that were much younger than them could be more of a symptom of a developmental disorder or something along spectrum type behavior. Kids who are on the spectrum tend to embrace relationships with younger kids. So you're just kind of probing here, seeing what it was like. Most of the time you're going to get, oh yeah, they were my age, or a year or two older, a year or two younger, and that's not a big deal. Any history of ADHD? What type it was? Did you have any problems with attention in school or work? Do you have any problems in concentrating in school or at work? Have you ever been told you were hyperactive or overactive? So these questions that are in italics are Some probing questions if someone says no to the history of a diagnosed ADHD. Asking some follow-up questions because it could be undiagnosed. In your session with them, this isn't a question you ask them, it's your observation. Are you observing, as the counselor, any motor or vocal tics in your client so far? Have you ever had trouble going to the bathroom in your clothes? Was this an issue when you were a child? Did you ever have difficulty in being alone? Did you have difficulty in leaving your parents or other loved ones? Did you ever eat things that you should not have eaten? Sometimes you'll get some strange looks from your client, like, what in the world type of question is that? But you really are, it's a question that is exploring pica, which, if you want to know more of what that is, I'll refer you to the DSM. Now, this next section for children only, do you get in fights very often? Have you ever hurt anyone or an animal? Have you ever stolen anything? Have you ever set any fires? Have you ever been caught destroying property? Have you ever done this and not been caught? Do you get caught in lies often? Or do you lie and don't get caught? Do you often miss curfew? And then we move on to just employment history. I'd generally like to know where people are currently working, if they're working, type of work it is, how long they've been there, have there been any breaks in employment for any particular reason. And then we move on to a medical history. So I don't need a really full and detailed medical history. I don't want them to tell me about every single broken bone or things that just perhaps aren't going to be relevant. So I will typically ask, do you have any significant medical conditions? So really wanting to know things related to, it could be diabetes, blood pressure, hypertension, COPD, anything that could be perhaps a chronic illness that will perhaps have an impact on their mental health. And I will ask who their primary care physician is, just for information purposes. Are you currently on any medication? So you'll see people who perhaps are already on some type of antidepressant or anti-anxiety medication. It's good information to know. I like to know who's prescribing that. I like to, and as a general rule, if I'm seeing clients who are receiving some type of psychotropic medication, I prefer them to be seen by a psychiatrist. Now, it's not the ideal for everyone, and not every person that comes to see you is going to want to switch from their primary care physician to a psychiatrist. It could be a higher copay because it's a specialist. But I like to ask the question to know who's prescribing, and if we go down a route of medication and deciding that a client might benefit from medication, then I will typically recommend that they receive it from a psychiatrist, someone who specializes in that type of treatment. And I generally will give an example in saying, if you have broken a bone, you probably would want to be seen by an orthopedist, someone who specializes in broken bones. And you would probably be referred to an orthopedist. And it's similar with mental health, that if you're experiencing a mental health issue, then you would want to see a physician that specializes in mental health issues, which would be a psychiatrist. The next segment here, are you pregnant, if it's a woman, obviously, or female? Skip that question if it's a male, obviously. Did you experience any significant childhood illnesses or injuries? Did you have any head injuries? Did you ever lose consciousness wanting to initial assessment as to cognitive functioning really perhaps could be a relevant point of information, particularly with all the research that's being done related to traumatic brain injuries these days, even from something related to kids playing football and receiving multiple concussions at an early age. So I like to just have this information, and it's really specific to head injuries. Do you have any allergies, seasonal or otherwise? What are you allergic to? Have you had any significant surgeries? How would you describe your sleep? How much sleep do you get per night on average? So you'll see some questions here: good, fair, poor, increased, decreased. You will ask some follow-up questions with this area. So you could get a response in saying, sleep's good, I get about 8 hours a night, which is good. And so I will ask a question, is this more than you typically get, or is it less than you typically get? And if I get a positive response to either one of those, then I want to know how long this has been going on. So if I've been sleeping about 10 hours a night, okay, well, how long has that been going on? What did you typically get before? When did that start? Why did it start, if you know? We'll get questions about, responses that people are saying, well, I'm not sleeping all that great now. I wake up. I can't sleep past 4 o'clock in the morning. Or I have difficulty getting to sleep. So the difficulty getting to sleep is considered initial insomnia. The middle insomnia is where they wake up in the middle of the night and then are awake for an hour or two and then eventually kind of go back to sleep. And that's also a disruption in their sleep cycle, which can contribute to their overall wellness. So I want to know that. That's middle insomnia. And for people who wake up at a certain point and then can't get back to sleep at all, that's terminal insomnia. So all these will have an impact. Any type of insomnia will have an impact on the mental wellness, mental health. This is information I want to know, and it will often, for me, be a factor in their treatment plan, is that we are addressing sleep. It could be an outcome that we're looking for, is that they're sleeping an appropriate amount, are able to get to sleep, stay asleep, and get a full night's rest. What's your appetite like? How many meals a day do you eat? Have you gained any weight recently? Have you lost any weight? How much? Is your appetite increased or decreased from what it typically is? Because those can also be indications of depression, as can the sleep. Do people complain to you that you need to gain weight? Do you fear gaining weight? Do you like your body? Have you missed any menstrual cycles for females, obviously? Have you ever had an eating binge? Have you ever felt like you couldn't control the amount you eat or cannot really stop eating? Have you ever made yourself throw up so that you wouldn't gain weight? Have you ever used laxatives, diuretics, or enemas or other medications to avoid gaining weight? Would you say that you exercise excessively? All these questions, and I pretty much ask them like that. All these questions are related to eating type of eating issue, eating disorder. Legal history, any involvement in any current lawsuits, past lawsuits, previous or current criminal cases? Have you ever been arrested? I'll sometimes get positive responses to that. Yeah, I was arrested when I was about 25. And I like to know why, what happened. Sometimes it can be an indicator of aggression, anger, relationship difficulties. It's just, for me, good background information to know some of these things. Are you currently involved in any church, synagogue, or mosque? What would you consider your religious affiliation? These are elements of support, a support system for individuals. Not that you would push that upon anyone, but it's good information to know. if they see that as a source of support. And then we move on to mood. Would you say that you're depressed? Would you say that you are often in an irritable mood? If I get a positive response, how long has that been going on? You find yourself having difficulty concentrating. How would you describe your self-esteem? Have you ever felt a decreased need for sleep? Have you ever felt an increased need for sleep? Are you more talkative now than usual, perhaps? Are you easily distracted? Have you ever started doing something that you find that you just can't stop doing? Would you say that you've spent just a tremendous amount of money lately? Would you say that you desire an excessive amount of sex? Have you made any foolish business investments? So once you get past the question related to self-esteem, these questions are tapping into a general assessment for mania, which is another element of bipolar disorder. So I get lots of no questions for all these, but I still ask them just because I want to assess them for mania. Then I move into anxiety. Have you ever had a panic attack? I will get positive responses to this for people that feel like they perhaps have had a panic attack, but wasn't really a panic attack. We'll probably cover this a little bit more when it comes to talking about these later in the semester, but generally a panic attack is assessed by the questions underneath that. So if you get a positive response on this, then you'd ask these follow-up questions. Have you ever had heart palpitations, pounding heart? Did you experience this during your panic attack? Were you sweating? Were you shaking, trembling? Did you have a sensation of feeling short of breath? Did you feel like you were choking? Did you have chest pain or chest discomfort? Were you nauseous, dizzy, lightheaded? Did you feel detached from yourself? Did you feel like you were dying? All these are symptoms for a panic attack. If you also get a positive response, okay, well, how many panic attacks have you had? How often do they happen? Here's a couple more on this next page. The numbness or tingling, chills or hot flashes. You don't have to have all these endorsed for someone to have a panic attack. They're all considered symptoms of them. But certainly just go through these questions, see what types of responses you'll get. Some additional questions related to agoraphobia. Do you have a fear of being in a place or situation from which it would be difficult to leave? Some examples: you're outside or you're home alone, being in a crowd, traveling on a plane or a bus or a car. Any of these situations create a great amount of fear for you. Do you generally make efforts to avoid being in these situations? So those two questions right there are really related to more of a general anxiety and agoraphobia. Have you ever had thoughts about things you just couldn't stop thinking about? These are obsessions. And then the next question, do you ever engage in behaviors that you really felt compelled or driven to perform that you really couldn't stop doing? These are compulsions. So those two questions are really tapping into obsessive compulsive disorder, OCD, which at least at one point was a category of anxiety disorder, which is why it's under that section of anxiety. The next section, previous abuse. Have you ever been abused or hurt in any way? If so, was it physical, emotional, sexual, any or all? If it was physical, emotional, sexual, if you get a positive response, who was the offender or offenders? Was any legal action ever taken as a result? When did it happen? Experiencing any other trauma? Have you ever witnessed something that was very traumatic? If you really get no response to experiencing any other type of trauma or not been abused in any way, you can skip the rest of this section, because these questions are follow-up questions to assess for post-traumatic stress disorder. If you get positive responses for either been abused or witnessed any other type of trauma, then you need to ask these questions. Do you have dreams of the events? Do you have recurring dreams, or have you ever dreamed of the abuse or the trauma that you witnessed? You ever feel as if the events are reoccurring? Do you try and avoid thinking about it, feeling anything related to it, or talking about whatever happened? Do you try and avoid those things? Do you ever try and avoid people or the places it happened, or anything that reminds you of the event? Are you unable to recall important aspects of the event? People have told you about things that you just didn't remember. Do you ever have just anger outbursts? You just angry at the world, or somebody really sets you off? You just having a kind of an explosion. Do you startle easily? Do you get scared really easy? Are you jumpy? So these are symptoms from post-traumatic stress disorder, and when you get a certain amount of these checked yes, then it's really indicated that the person has PTSD. From there, I move into some questions, and I usually will give a little transition and say, okay, now I'm getting ready to ask you some sometimes simple questions. Sometimes these are going to sound a little crazy, so just bear with me. This is the cognitive assessment portion. So I want to know, as a clinician, I want to know that they're kind of firing on all cylinders, that they're thinking the way perhaps they should be thinking, that they're intellectually intact, they're able to process things correctly. And I probably should rearrange this section with the substance abuse section. I should probably put substance abuse before cognitive assessment, because there was one point in time I saw a teenager who just completely blew this cognitive assessment. I wasn't sure what was going on with him. He wasn't answering some of these questions correctly. And then I got to that point in the substance abuse section, and he essentially admitted to having smoked some weed a little bit before our appointment. So it gave a little explanation to me as to why he wasn't thinking perhaps the way he should have been thinking. So I probably should move substance abuse earlier, but I just haven't gotten to that point. So, cognitive assessment, some general questions. What year is it? What season is it? And sometimes I get some looks of confusion, so I'll say, is it winter, spring, summer, fall? What is the date? What's the month and the date? What day of the week is it? What city and state are we in right now? For younger children, city and state, you may get inaccurate information. If you feel like that they know in general, then you just put correct. They don't have to be entirely accurate. If I get incorrect answers on any of these, you'll see there's a line to the right, is I will fill in what answer they gave, just to document it. I say, now I'm going to say three objects. After I say them, I simply want you to repeat them to me. Apple, table, penny. Now you say them. So they'll repeat them, and then you just kind of checked how many they got right. This can be a sign of dementia to a certain extent, or Alzheimer's, even if they're not able to immediately repeat what was just said to an individual. But for the most part, people reply correctly. Now I want you to subtract 7 from 100. It takes people a while to do this, so give them some time to do it. So 93. Okay, now subtract 7 from that. 86. Okay, keep subtracting 7 until I tell you to stop. So you see the answers are given there for you. It's 100, 93, 86, 79, and so forth. I'll let people go through, and to me it's okay if they are a little off. If they might say, 87, I'll say, well, it's 86, keep going. And they'll keep going. If they really, really struggle with this is what I'm looking for. Sometimes if I get them going and they get to 79 and I realize they're able to do the math and they're thinking correctly, then I'll just put number correct as 5, that they're thinking the way they should be thinking. So then I'll say spell the word world backwards, D-L-R-O-W. Okay. So these elements under attention they serve two purposes. One, you're able to see that they're intellectually intact by being able to complete these semi-difficult math problems and being able to spell backwards, functioning the way they should. But it also is a distracting element because I'm trying to test more of a short-term memory. So then once I get through these questions, I'll say, okay, what are those 3 words I asked you to repeat to me? And it really tests, because you've distracted them, it tests how well they're able to process and this delayed recall element. So I'm looking for them to reply with apple, table, penny. More times than not, I'll get 2 out of 3. And this, in the overall scheme of things, it may not mean anything, but to me it's at least information, good information for me to know in terms of this element of short-term memory, how well they're functioning cognitively. Naming. So this is another assessment towards dementia. I'll show a client in my office. I have a coffee table and a chair. And so I'll point to them and say, what's this called? And what's that called? And get them to name it. People with dementia or Alzheimer's sometimes have difficulty naming objects like that, or even stroke victims. So it's just kind of a cursory assessment when it comes to cognitive functioning. Now repeat the following sentence as I say it. No ifs, ands, or buts. Most clients will get that correct. Again, it's more related to cognitive functioning, dementia, elements of dementia. Sometimes we'll have difficulty being able to repeat a sentence like that. I generally don't ask a client, are you able to read, are you able to write, because in most situations they've already filled out a form for me. But it could be in the process of your assessment or context of wherever you're working, you may not have had clients do that, so you may need to ask them, are you able to read, are you able to write? We move on into psychosis elements. Do you ever see things that other people don't see? Have you ever had visions? Do you hear things other people don't hear? Do you hear voices that other people don't hear? And if I get a yes response, we kind of talked about this in a previous video here, is if I get a yes response, which ear do you hear the voices in? And I'm not going to repeat why I asked that question, simply because I mentioned that in an earlier video. What is your rating for suicide risk? Would you say you're a slight risk, moderate, or extreme, or immediate risk? What about risk for becoming violent? You have thoughts about hurting yourself or hurting anybody else right now. It's just a 0, 1, 2, or 3 rating here. I probably should put none with 0 rather than it say slight, both for 0 and for 1. This is probably just a typographical error. All right, so here's the section I mentioned before that I probably should move up in this assessment: is substance abuse. Do you now or in the past have you ever used tobacco? How about alcohol? How much do you drink? Um, how long do you typically do that? How often? How many times per week? When was the last time you used? And I'll go through some similar questions for illicit drugs, prescription drugs, over-the-counter drugs. Over-the-counter could be really looking for using pseudoephedrine or other types of dietary aids. Now, if they are endorse using alcohol or drugs, then I will ask questions related to withdrawal. Have you ever had withdrawal symptoms? Like, have you ever felt like that you just kind of jonesing for the alcohol or whatever drugs they were using? Have you ever experienced a blackout? What about hallucinations while you've been using? Have you ever thrown up as a result of your drinking or drugs? Would you say that it's created an element of depression for you? Have you ever had the delirious tremors, the DTs, or you ever shaken as a result of not being able to get alcohol? Have you ever had a seizure as a result of not having a substance or from using a substance? Also, tap into patterns of use. Would you say that you use more when you're stressed? Do you use when other people have stopped? And do you keep drinking when other people have stopped drinking? Have you ever lied to anybody about how much you have drunk or used? Do you try to avoid other people or kind of hide when you're drinking or using? Have you ever been drunk or high for several days at a time? Have you ever neglected something or someone when you've been using? Do you use more than perhaps what you intended to initially? Do you tend to increase or needed to increase your use in order to get high or become drunk? Have you ever tried to hide your consumption? Do you sometimes use before lunchtime? Have you found that you have difficulty limiting yourself once you get started? Have you ever promised somebody that you'll cut back but then been able to do that? Have you ever tried to stop in the past? And if so, what happened? How long did it last? What caused you to relapse? Have you ever been involved in AA or NA? All these types of questions you'd simply skip over if no one's really endorsing any alcohol or drugs, or any problematic behavior related to alcohol, I guess is what I should say, or drugs. And then with client input, this is where really I wrap up all the questions that I specifically ask the client. What types of things do you hope to get out of counseling? What would you say your strengths are, or your sources of support in your life? And that's really the end of the intake interview. The rest of the intake is documentation that I complete after the appointment is over. And so you could stop your questions with your volunteer at that point, and you're able to fill out this rest on your own. You do not have to fill this out with your client sitting there. So under appearance, I'm looking to see, do they look age appropriate? Do they look older, perhaps what they are? Do they look younger? This can speak to certain elements related to who they are. Maybe it could be drug use, who knows. Thin, obese, are they muscular, frail? Do they have a medium build? Are they well-groomed, disheveled, unkempt? Do they have a certain odor? Using lots of perfume? Are they dirty, unshaven, smelled of alcohol? Do they have some kind of bizarre hairstyle or bizarre makeup? All these could be symptoms of one element or another. Psychosis, substance abuse, depression. What were they wearing? Might describe in general, like jeans and a t-shirt. I'd use the check boxes to determine if they were neat, wrinkled, old, torn, clean, unclean, appropriate dress, inappropriate dress. All these things could be related to your assessment. What was their posture like? Rigid, slumped, cross-legged, slouched, comfortable, threatening? More times than not, it's just comfortable. You're really kind of looking to read nonverbals. The rigid could be related to anything, guarded, anything that might factor into your overall assessment of the individual. Do they have any distinguishing features, scars, tattoos, bandages, blood stains, missing teeth, tobacco-stained fingers? You're just thinking back to how they appeared to you. Any prominent physical abnormalities? Missing limb, jaundice, profuse sweating, a goiter, wheezing, coughing. Just really looking to provide, again, an accurate overall assessment as to who they are. Sometimes these types of questions will help me to remember who a client was. When your caseload is high enough and to the point where your times in between you see them are perhaps not as frequent as they should be to help you jog memory as to who they are, these assessments can be very helpful. Orientation, were they oriented to person, place, time, and situation? This is a typical question that psychiatrists really provide as their overall assessment as to who they are. So people who are psychotic in nature may not be oriented to all these elements. Someone who's considered intact in terms of their thought process, then they'll be oriented times 4, all 4 of these things. So most of the clients you see will be oriented times 4. Eye contact, was it good, limited, avoidant? And just as we talked about previously with people on the spectrum, their eye contact would be perhaps limited or avoidant. Behavior, did they appear just generally relaxed and calm, or were they restless? Were they rigid in terms of their movements? Did they appear agitated? Were they just slumped? Tense, tics, could be vocal or motor. Did they have any tremors? Their motor activity, unremarkable. Did they appear to have a motor retardation? So they move slowly, perhaps, unable to do certain things. Were they unable to sit still? Did they wring their hands quite a bit? Were they rocking back and forth? Were they picking at their skin or their clothing? Were they pacing? Were they perhaps catatonic? Did they have a tremor? Were they smacking their lips quite a bit, thrusting their tongue? These are some symptoms of schizophrenia. Did they have general mannerisms that stood out to you? Did they make lots of facial grimaces, which could be reacting to voices or hallucinations? Do they have vocal tics, motor tics, shuffling gait, again with schizophrenia? Did they appear to have limp extremities? Were they stumbling? What was their manner like? Was it appropriate? Were they trusting, cooperative, inappropriate, withdrawn, seductive, playful, evasive, guarded, suspicious, sullen, passive, defensive, hostile, manic, demanding? Did it seem like they had inappropriate boundaries, whether it be emotional or physical? Attentiveness to you, or did they seem disinterested, bored, internally preoccupied, distractible, attentive? What was their speech like? Normal? Was it slowed? Did they give long pauses before answering? Did they seem hesitant? Was the speech rapid? Was it pressured, monotonous, stuttering? Were they loud, soft, whispered, monosyllabic? hyper-talkative, perhaps too detailed, mute, clear articulation, mumbled, slurred. Again, can be symptomatic of a diagnosis or could just be information for information's sake. What was their mood like? Appropriate, depressed, irritable, anxious, euphoric, fatigued, angry, expansive. Affect. Was their presentation of their affect appropriate to the content or the circumstance? Were they tearful? Or was it blunted? Was it constricted? Did they appear to have a full range of affect, or was it flat, labile, excited, anhedonic, bright, or exaggerated? How about their thought process? Was it logical and well organized? Was it illogical? Did they seem to have a flight of ideas? Was it circumstantial? Did they have loose associations? Was it rambling, obsessive? Did they seem to have a blocking in their thought? Was it tangential? Was it spontaneous? Were they easily distracted? The thought content, did it seem appropriate? Did they seem to have delusions? Were they paranoid? Did they seem to have distorted thoughts, thought withdrawal, thought insertion, thought broadcast, magical thinking, somatic delusions, ideas of reference, delusional guilt, grandiose delusions, nihilistic delusions, ideas of inference, phobias? If you want descriptions as to those, you want to think back to the presentation on schizophrenia. Perception, hallucinations, they suffer from any type of illusions, visual hallucinations, audio hallucinations, or depersonalization. Suicide risk, this is your interpretation: none, slight, moderate, significant, extreme. If they indicate any type of thoughts of suicide, you're going to want to check either no plan or plan and then describe that in detail. Same thing with violence. If they appeared to have either slight, moderate, significant, or extreme risk towards violence, talk about plan versus no plan and describe in detail. If you get to the point where you're talking about no plan or plan in a description, in terms of an intake assessment with respect to suicide or violence, you're probably going to need to have some type of follow-up interaction immediately as a result of your intake. I don't want to go into too much detail with respect to that because this is just the assessment class, not intervention. But what you should understand is that when you get positive endorsements for either one of these things, it means you're going to need to intervene immediately. Judgment. Was it intact? Did it appear age appropriate? Did it appear that they were impulsive or perhaps immature or impaired? Did they seem to have poor judgment? The types of things they described. Insight into their problems. Did the insight appear intact, or was it limited, very limited, fair, none, aware if they have a current disorder, understands their personal role in problems? Their sensorium. Were they alert, drowsy, or did they appear to be in a stupor, or were they comatose? Memory. Did it seem intact or impaired? Intelligence. What is your overall impression as to their intelligence? Page 6 gives you a place to give a basic clinical summary. So this, for me, I typically will write something like, client was a 25-year-old male, female. Give a basic description as to who they are, their demographic information. I talk about why they have come into counseling and what they hope to receive from counseling. In terms of clinical impressions, that's where I might give, without rendering a diagnosis, is, client indicates symptoms of X, Y, and Z, whatever the case might be. And I could give some detail because it's as indicated by them endorsing A, B, and C. Recommendations, it's what you would recommend as a counselor for follow-up care. So it could be anything from follow-up counseling is not recommended to individual outpatient counseling is recommended, or inpatient is recommended. Whatever your thoughts are towards a follow-up care for your client. And then diagnostic impression is where you would render a diagnosis. Could be a tentative diagnosis, it could be a rule-out diagnosis, or it could be just a full-fledged, full diagnosis for your client. And then you would sign it and date it. And this would be the date of your meeting with the client. So this is it. I've walked you through the assessment. When I teach this class on campus, I actually ask for a volunteer in the class to kind of role play, and we go through, so you get to witness it in action, but it doesn't perhaps lend itself well for online instruction, which is why I've gone through this video here. There is a template, or should be a template on Blackboard that you can use. You simply print it out, meet with your volunteer, and go through this document in terms of what you need to submit for this assignment. You will notice on the syllabus it says complete an intake interview and mental status exam on your volunteer. There is content about it in Chapter 7, but this is the specific document you need to use. So print the template, meet with your volunteer partner, not a partner from the class, just a volunteer, and audio record you going through this interview and exam with your volunteer. You will upload your audio clip. You will also upload this document. So you scan it, or you can take a picture of every single page. You upload that into Blackboard, and then you will submit a critique of your performance. And so the link for the critique is something that you would type directly into text boxes on Blackboard. There's specific questions I want you to answer with respect to the critique. And that's it. Feel free to let me know if you have any questions, and I wish you luck on this assignment.